We're turning now to our good friend, Professor Rory O'Connor. Rory O'Connor is Professor of Health Psychology at the University of Glasgow in Scotland, President of the International Association for Suicide Prevention. He's an active user of Twitter, as many of you will know. He heads the Suicidal Behavioural Research Laboratory at Glasgow. He's published extensively, and particularly around psychological models of the processes which precipitate suicidal behaviour and self-harm. He's a co-author and an editor of several books, and his most recent book, When It Is Darkest, was published in 2021. And I believe that will be the theme of his talk this afternoon. So please welcome Professor Rory O'Connor, When It Is Darkest, Understanding Suicide Risk. Thank you.
Thanks, Donald, and I'm delighted to be here. Hopefully, I'm just trying to get my slides to share. Okay, so over the next 25 or 30 minutes, I'm going to talk about some of the work that we've been doing over the last few years in trying to understand suicide risk. And as Donald said in his introduction, I'm sort of going to frame it in the context of the book I published this year, When It's Darkest. And When It's Darkest, Why People Die by Suicide and What We Can Do to Prevent It is I suppose, my attempt to synthesize what I've learned over the last 25 years of working in the field of suicide research and suicide prevention. And it brings together, I suppose, my personal reflections as being somebody who's been twice bereaved by suicide, as well as what I've learned professionally and all the work that I've done and the countless people I've met over the years who've either taken part in our research or people who've been bereaved by suicide who've contacted me directly, or similarly people who have recovered from a suicidal crisis. And the book broadly covers the whole spectrum of suicide research and suicide prevention, and it's written for a general audience, for anybody with an interest in suicide, as I say, including those people who've been bereaved by suicide, those people working in the front line, treating people who are vulnerable to suicide, as well as family members and loved ones who are struggling or trying to understand suicide itself. So some of what I'll touch on today is covered in the book. So you can see here I touch on the background to suicide, the overview of who suicide affects, and I'll come back to that in a second. I'll then touch in my talk, as I do in part one of the book, on some of the myths and misunderstandings. And then part two of the book, again, which is covered in the talk, is trying to understand suicide. And I'll focus in on my model of suicide, the integrated motivational volitional model. And one of the key questions that we're trying to address in the field, and I often describe it as the holy grail of suicide prevention research, is to better understand the factors that lead somebody to become suicidal in the first place and how they're different from the factors that lead somebody to make that transition or crossing the precipice from suicidal thoughts to suicidal acts. And then the very last bit of the talk, I'll just hone in on a bit from part three of the book, looking at what works to prevent suicidal behaviour, how do we keep people safe. And I'll talk about some of the work we've been doing more recently on safety planning. And then the last bit of the book focuses in on asking those difficult questions around whether somebody's suicidal, or how you best support people who are suicidal or self-harming, as well as at the very end of the book, really dealing with the absolute devastation of surviving the aftermath of suicide. So again, the talk will touch on some of these key issues in the book, but as I say, the last thing to say about the book is it's trying to bring together people's stories, including my own story, my own career in research in suicide prevention, to give voice to people who've been vulnerable to themselves, those who've been bereaved by suicide, as well as those who've been have recovered. And it's really my attempt to try to weave in the science with people's stories, and I think that's the best way that we can make this science as accessible as possible. So with that overview then, just then to hone in on the rest of today's talk. So I'll touch on the scale of the challenge we face, and it fits quite nicely with Alan's talk just now, because I'll touch on some of the work that we've been doing in terms of monitoring people's mental health and well-being during COVID. I'll touch in on the myths around suicide. I'll probably talk just about two myths. Then I'll bring it straight into the IMV model, which is my model of suicide, and then this key question of how we better understand those who make the transition from thoughts to acts, And then I'll touch in on some of the work that we've been doing more recently on safety planning, and then hopefully bring it together with some conclusions. So much of the work that I'll talk about today is conducted in collaboration with many of my colleagues at the Suicidal Behaviour Research Laboratory at the University of Glasgow, as well as obviously national and international collaborators. And of course, like all of us involved in research, we're incredibly grateful to the funding support we do receive from all of these sources here, which include obviously our standard research councils, Scottish Government, NHS Scotland, Public Health Scotland, as well as obviously other charities. And then that's in terms of where the work's done. The challenge then is understanding the scale of the phenomenon that I've been sort of trying to understand for the last 25 years. And part of understanding the scale of the ripples of suicide is for us to think, first of all, in a global context. We know about 703,000 people die by suicide each year. And for each of those people who die by suicide, Julie Carell, a clinical psychologist in the US, has estimated that about 135 people are directly affected by each one of those deaths. So if you then do the mathematics and scale that up, potentially then globally each year, about 95 million people are affected by suicide or knew the person who's died. And some of those will obviously require clinical care, and hopefully most of them don't. But it still gives you a sense of the ripples of suicide. Or another way of characterizing it is that every 40 seconds somebody dies by suicide, and at the very least another 20 will attempt suicide. And these numbers are likely to be underestimates, because we know there are huge issues with national reporting biases and challenges in different countries in the world for suicide, and in many countries also do not record suicide attempts in a robust way. And I think that is a challenge moving forward, that we get better data, and that includes getting better data in the UK and in Scotland as well. And then in terms of the Scottish context, then 805 people we likely died by suicide in 2020. On a positive note, that was a slight reduction from 2019, but still much higher than we are in England or in other parts of Wales, for example, and other parts of Europe. Again, consistent with other countries, 71% or between 71 and 75% of all suicides are by men, and there's this huge inequalities gap. And I'll return to that inequalities gap when I look at the impact of COVID in a couple of slides' time. So that highlights then the scale of the challenge we face. So we've obviously this huge inequality. At least 3 times more people died by suicide from disadvantaged areas, from more affluent areas, and that was before COVID-19. And one of the things we've been doing since the onset of COVID-19 is trying to understand, predict the impact, but hopefully also be able to intervene, so that our concern at the beginning of the pandemic, that there was this perfect storm of factors which could lead to an increase in suicide nationally and internationally. And there's lots of different studies that have been published since then, but the most comprehensive study published to date was led by Jane Perkis in Melbourne and Anne John in Swansea, and under the auspices of the International COVID-19 Suicide Prevention Research Collaboration, there was a whole group of us got together internationally to try and understand and mitigate any risk which may emerge. And this paper published last year looks at the impact of COVID-19 up until the end of July last year. So as you'll see in a second, the data are reassuring, but it only covers that early phase of the pandemic. But it's easily the most comprehensive study that's been conducted to date. And the conclusion from that study from 21 countries, when you compare the suicide rates in those first few months of the pandemic to pre-pandemic rates, the good news was that there was no evidence of an increase, that the suicide numbers had remained largely unchanged or actually declined in some countries in those early months. Now, much of the data are from high-income countries. We have to be vigilant when we think about the impact globally. But the other issue is that, as we all know now, things have changed markedly since that July 2020. And we're now, as we recover from the pandemic, that recovery with now furlough being removed, and as we all recover in different ways, and there's clearly inequalities and vulnerabilities which existed before the pandemic, which really highlight the importance that we don't take our eye off the ball. And with that, as you'll see in a second, there are some concerning signals from data we've got from the UK that mental health has been affected, not for everybody, but in some groups in particular. So vigilance is a key message as we move forward, but reassuring thus far. So, as I said a second ago, there are some signals that we've got from some UK data which highlight the importance of thinking beyond the suicide statistics themselves. Now, the other thing to note about the paper, that Lancet Psychiatry paper I've just touched on, is that it only looked at suicides across the adult population. It was unable to do any fine-grained analysis by gender, by age group, or, for example, by people with pre-existing mental health problems, or those from many different social backgrounds. Now, at the start of the pandemic, we were fortunate that we were able to establish the UK COVID-19 Mental Health and Wellbeing Study, and it was funded by Samaritans, Sam H. and the Mindstep Foundation in collaboration with the University of Glasgow. And since the end of March 2020, we've been monitoring a broadly representative sample of the UK population in terms of mental health and well-being. And what I'm going to focus in on for the first part of this is talking about the first three waves of the data from that. And the first three waves of the data cover effectively the first 6 weeks of the pandemic. So from the end of March until the start of May. And I'm really just going to hone in on the suicidal ideation indicators at this stage. Again, we have a whole range of measures which are included in this paper, obviously indices of depressive symptoms, anxiety, loneliness, well-being, and so on. I'll return to some of those in a couple of slides' time. But the main focus is trying to track people's mental health in the context here of suicidal ideation. So the data, if we look from the first 6 weeks, you see this significant increase in suicidal ideation. And over a very brief period of time, those 6 weeks, that early phase of the pandemic, where there was huge uncertainty and huge concerns, such that by wave 3, 6 weeks in, about 10% of the population were reporting suicidal thoughts. Now, we are also doing work with Scottish Government. Scottish Government have also funded a tracker study, and everything I say today with regard to the UK study is also found and is consistent with data also being recorded and collected in Scotland only. So some concern that we can see this increase in suicidal ideation indicators in the early phase of the pandemic. But then if we do a deep dive in terms of who's most vulnerable, who's most likely to report suicidal thoughts, this green line is important. So that's the young people. And again, that's consistent with one of the things that Alan Carson has just said in terms of his data, is that the young people seem to be most affected. So I agree that most people have been broadly resilient if we look at sort of national rates, but we do have elevated rates in particular in young people. In this case, young people is 18 to 29. And then also, if we look at male-female differences, although it looks as if women are reporting significantly higher levels of suicidal thoughts compared to men, that difference is not significant. Okay, so that's young people, one vulnerable group that we need to be vigilant about for the first 6 weeks. Again, two other groups which I've mentioned already in the introduction to my talk is those from more socially disadvantaged backgrounds. And again, the blue line represents those from lower socioeconomic groupings. Again, across all waves of the early phase of the pandemic, those first three waves, there's evidence of increases in suicidal thinking. And indeed, if we focus in further in another group, those individuals with pre-existing mental health problems, obviously reporting mental health problems before the pandemic, we see this stark difference. So across all of the three waves of the first 6 weeks of the pandemic, 20% here of people with pre-existing mental health problems are reporting suicidal thoughts, compared to only 6% of those with no pre-existing mental health problems. So that was the first 6 weeks, the first three waves of the pandemic. I'm just going to show you a couple of slides now, I think it's 3 or 4 slides, which brings us bang up to date. So what's happened to people's mental health and well-being, in these cases focusing still on suicidal thoughts from waves 4 right up until wave 8. And wave 8 of our study covers a period right up until July of this year. And again, as you can see in the right-hand box at the bottom, it gives us some reminders of what was going on in terms of where we're at in terms of lockdowns or easings of lockdowns across that time period for the UK context. And of course, I recognise that there are differences in implementation across the 4 nations of the UK. But reassuringly, if you look in the left-hand figure here with suicidal thoughts in the last week, we see it looks pretty stable. So there's a bit of an increase from wave 3 to wave 4. It's a non-significant increase. Then things are pretty stable, with what seemingly looks like a reduction at wave 8. And wave 8 is when we were easing from lockdown, when things were starting to get back to some semblance of normality. But again, if we do a deep dive into our age profiles, we see this concerning trend of our young people still being adversely affected. And indeed, this 20% reported at wave 7, when we were in the midst of lockdown, our last lockdown, we hope it's our last lockdown, 20% of our young people reporting suicidal thoughts. That is the highest rate of suicidal thoughts that our young people had reported across any phases of the pandemic. But again, the good news is wave 8, we start to see some semblance of recovery. And again, if we stick with the waves 4 to 8 and look at another indicator, look at depressive symptoms. So depressive symptoms, just using the cutoffs from the PHQ-9, again, we're seeing some semblance of recovery. A peak again at wave 7 when we're at the height of lockdown, and then we're starting to see some recovery. And hopefully, when we do the next wave of data collection, we're hoping that we'll see continued recovery. And then just two other indicators from the most recent data: loneliness and well-being. So again, there's been this whole concern on loneliness increasing, and indeed, we recently published a meta-analysis. It doesn't cover post-pandemic times, but led by my colleague Heather McClellan, which shows that loneliness itself is a stark prospective predictor of suicidal thoughts and suicide attempts over time. So it is important that we monitor loneliness, as obviously governments in the UK and in Scotland are doing now. And again, I think it's nice to end with this. In this section, I'll talk on the well-being measures. We can start to see our well-being increasing as well. So the key take-home is, yeah, lots of people were protected, but the mental health and well-being of certain groups of people, young people, people from more socially disadvantaged backgrounds, and those with pre-existing mental health conditions, there's 3 groups of people which require our care, support, and attention moving forward as we recover, because that recovery will be bumpy. And then just one last slide on COVID-19 stuff before I move on to the second half of the talk. So we've talked about suicidal thoughts, and we've talked about suicide deaths. Again, a few months ago, there was a meta-analysis published, again, covering the early phase of the pandemic, covering 54 studies, including some of our data. And what's clear, if we look at the conclusions from this meta-analysis, if we look at non-fatal suicidal behaviour, that there seems to be evidence of increased event rates, yes, for suicidal ideation, as I touched on already, as well as suicide attempts and self-harm. So again, it's a marker of this as a proxy for suicide risk moving forward, that these indicators, these non-fatal indicators, highlight the fact that we need to ensure that mental health remains a priority. Okay, so that's the end of what I'm going to say about the COVID-19 stuff and the scale of the challenge we face. I want to just say a few words about myths around suicide before I'm moving in and talking in detail about sort of the factors around suicide and the IMV model. So basically, I just want to, this is again taken from my book, but what's really of interest to me when I was reflecting on writing the book was, one of the things I thought I would try and understand was whether the myths around suicide have changed or been challenged in the last 25 years that I've been working in the area. And this list of 14 myths is taken from a talk I gave in the 1990s. It was my first talk I did in Belfast. I talked to the general public on suicide, and I garnered this list from our textbooks and other studies out there. And the reality is that although we've made a lot of progress in terms of the myths around suicide, when I went to sit down and write the book again, I realized that these myths, yes, they've been challenged, but still persist. And I'll just touch on one of them for the purposes of today. That's number 4. Asking about suicide plants the idea in someone's head. Again, it's an important myth because there's no evidence that that's true. Indeed, there's evidence for the contrary. So just to be clear, that asking somebody whether they're suicidal, there is evidence that may get somebody the help and support that they require. It could be the start of a life-saving conversation, but there's no evidence that it leads to planting the idea in somebody's head. So the take-home message is, please, if you're concerned that somebody is suicidal, please ask them directly. And again, there's lots of other myths there, which again, if you're looking to know more, were described in detail in the book. So yes, we're making progress in terms of challenging some of those myths, but I think that not only have we a long distance to go, I think our narrative around what we describe as serious mental illness, I think, is probably lags further behind things like anxiety and depression. I'm not saying they're not severe, but in the context of their presentation in general population settings. Okay, so in the last 10 or so minutes, I want to just focus in on understanding. And if we're trying to understand why people become suicidal, we have to take a biopsychosocial approach. And of course, we'll all be familiar with that. But the reason I suppose we're putting this slide up is a slide we published a couple of years ago now, but was to recognise the importance of taking a developmental perspective. And a lot of the work that we do, for example, in the Suicidal Behaviour Research Lab, is looking at the impact of early life adversity or early life trauma on not only on people's psychology, but on their attachment relationships and on their stress response. And it's recognising that understanding that interplay between the psychology, the biology, and the social, cultural, and clinical factors is at the heart of understanding suicide risk. But what I'm going to focus in on in my last 10 minutes are on these proximal factors. And in particular, at the very bottom here, you can see this sense of trying to understand that suicide is not usually driven by somebody's desire to end their life, but their desire to end unbearable mental pain, because that sense of hopelessness and that being trapped by mental pain and feeling a burden on others is a key driver to the emergence of suicidal thoughts. And then the other bit I'll touch on is this transition from being trapped to having thoughts of suicide, and then going from thoughts to acts of suicide. And that's where my IMV model comes in. And the IMV model was my attempt first of all in 2011 to bring together, integrate our understanding of why people become suicidal. And then in 2018, with my colleague Olivia Kirtley, we updated the IMV model. And for the purposes of today, I'm just going to make two key points about the model. The first is that the factors that lead somebody to become suicidal are different from the factors that lead somebody to act on their thoughts. So this middle bit is the motivational phase. That's trying to understand the emergence of suicidal thoughts. And then the volitional phase on the right is trying to understand the transition. These volitional phase factors are key to governing the transition from thoughts of suicide to suicidal acts. And so although, as I said in the previous slide, there are a whole range of factors across a whole number of domains of risk which increase the likelihood that somebody becomes suicidal, to my mind, suicidal thoughts emerge ultimately, they're a psychological phenomenon, because and the decision to act on your thoughts is a psychological phenomenon because you make a decision that life is so unbearable and that suicide is my ultimate way of trying to end that pain, and I make a decision to act on those thoughts. But ultimately, in a parsimonious way, suicidal thinking emerges when people feel defeated and or humiliated, from which they feel trapped. And it's that sense of entrapment is a key driver of suicidal risk. And there are a whole range of other factors outlined here which help us understand the movement from defeat and humiliation to entrapment, and from entrapment to suicidal thinking. And those feelings of defeat and entrapment could be triggered from feelings of loss or rejection or shame. But at the heart is that the key driver, though, as part of the final common pathway, is this sense of entrapment. And we'll return to this transition from this transition from suicidal thoughts to suicidal acts, these volitional phase factors, in a couple of slides' time. So I've made a big song and dance about the importance of entrapment. And we and others have done a number of clinical and non-clinical studies and prospective and case-control designs to try and look at the role of entrapment. And here's just one, as a 12-month perspective study. And again, all I want you to take from this slide is via that. Oh, somebody's mute there. I'm getting background feedback there. Thank you. So the key message is, when we're trying to predict suicidal thinking over time in this 12-month study, people's internal mental pain, this internal entrapment, is a key predictor alongside feeling a burden on others. So it really highlights the importance of entrapment. And again, we've shown this across a range of populations, across a range of settings, and a range of age groups. So the obvious question is, well, how do we go about assessing entrapment? And we usually use a scale, a 16-item scale developed by Paul Gilbert and Steve Allen in the 1990s. But more recently, we've developed an abridged version of that scale, a 4-item version in clinical and non-clinical samples, in the hope that if we can go for this briefer version, it's more likely to be incorporated in clinical practice, and it's more likely to be used in research context. And again, we did that, and you can see if you look at the correlations here between the 16-item scale and the 4-item scale, pretty almost perfect correlation. Again, I'm getting this feedback again. Can somebody mute, please? So the 4 items we developed are simple as this. These are the 4 items. So things like, I feel trapped inside myself. So it's pretty direct, understanding the sense of that sense of entrapment. I'm trapped by this mental pain. So my message would be, if we're trying to understand suicidal risk and track that, we should be tracking people's feelings of entrapment. And because we know those feelings of entrapment wax and wane, they come and go. Okay, so that's all I'm going to say about entrapment. And in the last 5 minutes, I'm just going to finish with this key message of understanding the difference between factors that lead somebody to become suicidal, which are these motivational phase factors, and the factors that lead to the transition from thoughts to acts, these volitional phase factors. And these factors which increase the likelihood that somebody crosses the precipice from thoughts to acts. And again, this quote is taken from a conversation I had with a mother some years ago who devastatingly lost her son to suicide. And she never stops asking herself the question of why, what could she have done differently? How could she have understood, or how could she not have seen that her son was going to act on their thoughts of suicide? And it's notoriously difficult. But my volitional phase is my attempt to try and understand that transition from thoughts of suicide to suicidal acts. And so all I've done here, this figure is simply the right-hand bit of my graph, or my model, blown up to make it a bit more comprehensible. But in essence, the argument is, in the middle here, we've got 8 volitional factors, and they're all described here. And the message is that if somebody's having thoughts of suicide, and if they get the presence of these volitional phase factors, they're more likely to act on their thoughts of suicide. They're more likely to cross a precipice. So things like having ready access to the means of suicide increases the likelihood that somebody will act on their thoughts of suicide. Or knowing somebody, a family member or friend who's died by suicide, this third one here, exposure, increases the likelihood that somebody will act on their thoughts. Or impulsivity is another factor. Or if you go to the second last one, mental imagery about dying or death. So we know if that mental imagery seems to act as a rehearsal mechanism, which in combination with having thoughts of suicide, increases the likelihood that somebody will act on their thoughts. And again, we and others have published a number of studies now supporting the central utility of focusing on these volitional phase factors and distinguishing people who have thoughts of suicide from those who act on their thoughts. So again, my key message, the key take home before the last couple of slides is trying to really, if somebody is having thoughts of suicide, we should try and ascertain the presence of these volitional phase factors and then mitigate risk thereafter. And then just then to bring this hopefully to a logical conclusion in terms of mitigating risk, what we're trying to do is intervene. If we can't stop somebody becoming suicidal in the first place, can we intervene to interrupt the transition from suicidal thoughts to suicide attempts? And the good news is over the last 10 or 15 years, there's been a growing interest and growing evidence base for these psychosocial interventions in particular. Especially, there's been this growing focus on brief interventions. And these brief interventions, like safety planning, have taken precedence in recent years. And remember, safety planning is just a simple intervention which tries to get people to identify the warning signs that they may be becoming suicidal, and then ways of keeping themselves safe, both internally and externally, as well as keeping their environment safe so they don't act on their thoughts of suicide. And we recently published a meta-analysis led by Channy Nuge in the Netherlands, looking at safety planning interventions and the evidence base for reducing future suicidal behaviour. And again, from the small number of studies that have been published, there's growing evidence to support the utility of these safety planning interventions. And indeed, when we've done this in Scotland, we've recently completed, or a couple of years ago now, probably with the pandemic, we've completed the Safe Health feasibility study. This was both doing safety planning in the emergency department following a suicide attempt, plus offering 45 weeks of telephone support, weekly support in that hiatus between discharge from hospital and potential ongoing care. And again, a couple of key take-home messages before I finish on this. So again, we did a process evaluation as part of this study. And again, we did these 45 telephone calls following the suicide attempt to speak to people and risk assess people and maybe update their safety plan in those 45 weeks. And just two key findings were, first of all, people do discuss the content of the safety plan on these telephone calls. Really highlights the importance when you're doing safety planning. It is collaborative and it's not a tablet set in stone. It's a dynamic document which should be updated. But crucially, in that window where we know vulnerability is high in those weeks following discharge from hospital following a suicide attempt, almost 80% of our intervention participants said that they actually used the safety plan in that period of time. So that potentially saved their lives. But one of the questions we've yet to address in the literature is, we don't know yet to what extent safety plans on their own work in isolation. What are the active ingredients? Because that meta-analysis I talked about earlier incorporates interventions which safety planning is part of their intervention. Okay, so that's our whistle-stop tour. Let's try and bring it to a close as we're just at 30 minutes. And what I tried to illustrate is that the importance of seeing suicide is more about ending pain rather than ending one's life. It's this idea of being trapped by mental pain. And if we're trying to prevent suicide, it takes so much more than just treating mental health problems. Of course, that is important. But our COVID highlights the issue of inequality, and obviously not just inequality in terms of social inequality, but inequality across the lifespan, as well as those people with pre-existing mental health problems. And then lastly, the last point I tried to highlight was that the factors that lead somebody to become suicidal are different from the factors that lead somebody to cross that precipice from suicidal thoughts to suicidal acts. But then lastly, just the very last line of, or a couple of lines in my book, I think is a good way, hopefully, to end. And it's this idea when we're thinking about suicide prevention, that although we can never bring back those who we have lost, we can better support those left behind. And if we work together, we can save more lives. And my ultimate hope is that as a society, if we are kinder and more compassionate, both to ourselves and to those around us, then we will go some distance in protecting all of us from the devastation of suicide. Thank you.
Thanks very much, Rory. I think we've got a few minutes to give you a chance to answer some questions. And we have one question in the chat at the moment from John Sawkins. There's evidence that the number of suicides actually reduced during the Troubles in Northern Ireland. Have you any thoughts about that, Rory, and how that relates to the IMV model?
Yeah, that's as a Northern Irish person, this is something that I've been obviously interested in ever since I did my PhD in Belfast on suicide in Northern Ireland. So yes, there's evidence not just in Northern Ireland, but in other countries that when conflict is high, suicide is low. And that's linked to we think it's linked to that sense of connectedness or social cohesion, which is associated with times of war or conflict. And also that sense that your own personal concerns take secondary precedence over the community's concerns, and we think they're protected. And in terms of the IMV model, there's two things of note there. So I didn't go into detail here, but that sense of if you're feeling trapped, the likelihood you going from trapped to suicidal thoughts is moderated, is buffered by social support or social cohesion, and that's in the model. So that would be, so I would argue that even though people still experience distress during the Troubles, the likelihood of acting their thoughts, the likelihood to become suicidal is reduced because of the sense of cohesion. But great question.
Thank you. And I have a question of my own here, which is really just thinking about economic and social factors being really important in affecting suicide rates. And so far in 2020-21, in the pandemic, we've had a lot of social factors that have increased distress, but many people have been protected from the economic effects of the pandemic by the Chancellor and the government. Do you think that we are likely to see economic effects biting in 2022 And do you think that's when we'll potentially see a significant increase in suicide?
Yeah, well, so I hope we don't see that increase, of course. But I am concerned that, yeah, so we've been protected by furlough, and not just furlough, a range of other social measures. But my fear is moving forward, the groups we mentioned, those three groups, and that's just three groups, there's lots of other groups who are vulnerable. Young people, young people's my biggest concern, because pre-pandemic, young people's mental health problems have been increasing anyway. And then we had this, obviously, I think this additive effect of COVID. A lot of young people feel a sense of hopelessness about the future, and their futures have been adversely affected by the pandemic. So without a doubt, I think we need to be vigilant. And one of the things the Scottish Government did, and we just think in the Scottish context, first of all, is that when the pandemic kicked off, a number of us, as part of this collaboration, published effectively a piece in Lancet Psychiatry, which we said, here are things that governments could think about doing, not just governments, other organisations could do to mitigate risk. And actually, the Scottish Government went through that document and looked to see what we could do in Scotland. I think we did a lot of really good stuff during that. Now, I think the challenges are different, and we've published another paper as part of the collaboration more recently, what we should be doing moving forward. And I think part of that is protecting these particular groups, especially what else we can do to mitigate the economic and social consequences. And I think we all, have the responsibility to ensure that at all levels, that not only do we protect in terms of economic consequences, that those pathways to care and support are as transparent and as accessible to everybody. I think that's something we all can do.
Thank you, Rory. We've got time for one final question from an anonymous person in the chat saying, it's a methodology question, given the new MRC guidance on evaluating complex interventions, how would you evaluate a safety planning intervention going forward? Would you consider realist methods or another method that takes context into consideration?
Yeah, absolutely, yes. And so as part of the process evaluation we did, we adopted a realist approach, and so in advance we've obviously a logical model for how we think. There's multiple me's appearing on the screen, which is really we developed a logical model in advance, which looked at, we've obviously very important boxes, and not just boxes, but obviously recognition of the contextual factors, but at all levels, systems levels. Those contextual factors can be systems level or community level or broader. So absolutely, having a realist approach, having an embedded process evaluation is absolutely central to me. Any evaluations that we do, and so I totally agree with that question and comment.
Thank you very much, Rory.